All right, well, I think let's get started. My name is Carrie and I'll be moderating today. And first of all, thank you for taking the time out of your day to join us at the 2020 Child Right Policy Forum, the virtual edition, as everything is this year. As we start, I wanted to introduce our panelists. So panelists, if you don't mind, just give a wave in case people are looking. We have 4 great panelists with us today. Arlene Reed, our 5th panelist, was unable to join us, but we will be getting her comments a bit later on today. But we wanted to start with Al Edmanski. Give us a wave, Al. Hello, welcome. Al is a disability activist, a community organizer, and author. He is a recipient of the Order of Canada. He was involved in establishing the world's first savings plan for people with disabilities, right here in Canada, the Registered Disability Saving Plan. He's also the parent of Liz, who is a spoken word poet and artist, and who introduced him to the disability world. So welcome, Al, and thank you for joining us. Next up, we have Jeff Butler. Jeff has extensive public service experience. He is currently involved with the Ontario Ministry of Education. His current role is Assistant Deputy Minister, and he works in student support and field services. Previously, he was the Director of the Early Years and Childcare Policy. Thank you so much for joining us, Jeff. We have Lillian Kitcher. Lillian is a parent navigator with CHEO, that's the Children's Hospital of Eastern Ontario Navigator Program, which provides non-medical supports to help parents and caregivers caring for children with complex medical needs. She's also the mom to a child who is medically fragile and complex. We have Tui Mei Lu. Give us a wave, thank you. She is a pediatrician and clinical researcher at the Neonatal Follow-Up Clinic of St. Justine Hospital. Her research focuses on long-term neurodevelopment and physical health outcomes following preterm birth. So thank you for joining us and welcome to you all. As we get started, I have put a land acknowledgement in the chat box because we are all coming from different places. And as a settler on this land, I just wanted to personally thank the Indigenous people of the past, present, and future from all across this nation. I recognize the privilege I have and the injustices that have been and are still being committed against Indigenous people. I hope that each one of us can find a way to move forward in the spirit of reconciliation in our own communities and in the country as a whole. So please, if you have a land acknowledgement for your region, please feel free to also put that into the chat. So thank you very much, everybody. Oh, and there's a wonderful UBC campus. So just a few Zoom guidelines. If you don't mind, to reduce the background noise, please keep your microphone muted, except for the panelists who will be speaking. And if you don't mind also, please disable your webcam at this time if you are able to, just so that we can see the panelists as best we can. We also suggest that you enable active speaker view because the panelists will be speaking one at a time. That way you can see them. Do that in your top right corner of Zoom. You can see there's the little red square. Just make sure it says speaker view and click on that, and that should get you going. During this, we will be using the chat box. So if you have any thoughts or comments or questions that come up as you're listening to panelists speak, feel free to put them in the chat box. We will be taking that chat, we will be keeping it and putting it as part of the information we have gotten from this policy forum. So please feel free to use that chat box. Do that, you click on the chat button in Zoom, a little box will pop up. You can type your questions, your thoughts, anything in that field. Make sure it says to everyone because Pierre will be keeping track of some of the questions. He's also from Child Right, he'll be keeping track of some of the questions for me in case the chat gets really going. So make sure it goes to everybody and then you can hit enter and it'll send it. All right, so pretty much enough of me talking. Let's get started with our questions and our panelists. So I'm going to stop sharing the screen so we can see everybody's lovely faces. So before this forum, we actually had key stakeholders get together and come up with questions, thoughts, issues that were happening because of COVID-19. So we're going to start with those questions. I'm going to start by asking Jeff a question about education. So Jeff, since returning to school, children with underlying conditions who are at increased risk for complications with COVID-19 and those who are unable to wear a mask are being segregated from their peers, can we come up with a new way to stay safe while committing to inclusionary measures?
Hi, everyone. Good morning / good afternoon. It's afternoon here in Toronto. Thank you so much for the questions. I'll start by, I think, just acknowledging the really significant impact that the pandemic has had on people with disabilities, including students. This is something I think, we were aware of would be the case from the start, and so something that here in Ontario, we've built into our planning. So I want to talk about a couple of things really briefly. First of all, how from an Ontario standpoint, we've approached the protective measures in place in school generally, and then the specific measures that have been put in place that are related to children and students with medical vulnerabilities or with special needs. And I think both are sort of salient in respect of the question. So we released our school reopening plan in June at the end of the previous school year. And since then, we've released a number of different pieces of guidance, particularly our COVID-19 management in schools guidance in August. And I would say, all of what we have put out and the planning that's gone into the reopening of schools for this school year is really predicated on the idea of multiple layers of protection, not any one particular measure. So it's certainly the case that mandatory masking for students in grades 4 through to 12, as well as staff, and the encouragement of masking for students in kindergarten through grade 3 is certainly part of our plan. We have built in exemptions into that for students and staff members that do have medical needs. But what is really important to understand is that this is not the only measure in place. There are many more things that have been put in place. And the idea is, first of all, the more, I think, strategies that you can layer on top of each other, the more protected you are overall, but also as an acknowledgement that, in some instances, not all of the strategies are going to be feasible. For example, masking for, individual students or individual staff members on a case-by-case basis where, for medical reasons or for whatever other reason, that's not going to work. So we've put in a number of other strategies in place. I think one really critical one that I think has proved out to be really critical this school year is cohorting. So keeping fixed groups of students and a teacher together throughout the day, and really limiting the opportunities, acknowledging that there's going to be important interactions between the students within those cohorts, but limiting interaction across cohorts of students. We've really encouraged distancing as much as possible and taken steps to try to reduce class sizes and leverage more space in schools, non-traditional sort of instructional space to allow more space for kids to spread out in their schools. The school environment looks very different this year. For example, if you go into a school in Ontario, you'll see sort of traffic flow markers, on the floors or on the walls, making sure that people are moving in kind of uniform directions throughout the schools, distance markers, those sorts of things. Enhanced cleaning protocols throughout the school. Adapted delivery and timetabling approaches in secondary school. So in our higher risk areas of the province, that is areas of the province that have seen higher incidence of COVID-19, we're looking at high school models where students are not attending full-time, they're attending sort of part-time in person and part-time virtual, and that's so that cohorts that are in person together can be smaller. Mandatory screening, so that students and staff are screening for symptoms of illness and being directed to stay home if they are ill. Additional support for HVAC upgrades, outbreak protocols that we've provided to boards and local public health units, local public health officials with clear roles and responsibilities. So the message I just want to get across here is that, we really have tried to layer in a number of strategies that are intended to both prevent COVID-19 from coming into schools, and then where it is into schools, limit the opportunity for it to spread throughout the schools. And what that means is we are able to do things like masking exemptions for students, for example, who are not able for medical reasons or whatever other reason to not wear a mask, and knowing that there's, not everything hinges on masking as the one protective measure. There's multiple layers in place. The other thing is, how we've prepared to support students in and out of physical school. So this year we have given parents the choice, not just parents of students with special needs, but all parents, the choice of whether they're going to have their student attend in-person school or whether they will attend virtually. That is something that for parents and students that have medical issues, we've advise them to consult with their medical providers about what is the most appropriate arrangement for that student, and where, regardless of what choice the parent and the student make with respect to whether they're going to participate in school in person or virtually, that there are appropriate supports in place and that they can be included in the programming. So, for example, where a student that has medical fragilities, for example, does make the choice in consultation with their healthcare provider to attend in-person school, we have worked with the healthcare sector on guidance for how can rehabilitation services or nursing services that they need in school can be provided safely. So for example, students who depend on aerosol generating medical procedures throughout the day. So we have worked with the healthcare sector on how can that be done safely in a school environment. Individual health regulatory colleges have also put out guidance to their members on how they can continue to support students in school. Again, masking exemptions I mentioned already. We think it's important that students not being excluded from school just because they're not able to wear a mask. And so again, that's why there's multiple other strategies in place. For students that have made the choice and parents that have made the choice for their students to attend virtually rather than in person, most of our school boards have set up virtual schools. There are significant numbers of students that have chosen to do virtual schooling this year. So they're organized into virtual schools within their school boards and included in virtual classrooms along with their other peers. We're also mobilizing special education supports for those students who are learning at home. So for example, many students have specialized adaptive equipment that they need to participate in the school day. And so we've worked with school boards to make sure that that equipment, to the extent that it lives in the school, is been distributed out to students in their homes so that they have it. We've made sure that the technology platforms that are being used to deliver virtual schooling are accessible to people with disabilities. And we've directed boards to make sure that they're mobilizing their education assistants in the virtual schools to be able to support students who do need that educational assistant support virtually with their learning, helping out their parents where their parents are supporting their learning. So we have really tried to, regardless of what choice the student makes and the parent makes around whether they're going to attend in person or virtually, that the right supports are there and that they're included. I acknowledge that not everything has been perfect. And as I said at the beginning, there has been a disproportionate impact on people with disabilities, and we're learning as we go. We're consulting with members of the disability community, with parents, with healthcare providers, and we're kind of iterating as we go. But that's sort of what we've done in Ontario, and I know other jurisdictions have taken similar approaches. Thank you.
Thank you, Jeff. Did anyone else want to jump in on that one before we move on? Thank you, Jeff, very much. So I'm going to throw the next question over to Lillian. So Lillian, families caring for children with developmental conditions start off with higher financial burdens, both because of the cost of medical equipment and therapies, as well as limited employment opportunities. In what ways can the social safety net and support services be better enhanced to meet the needs of financial obligations of families now?
Thank you for that question. Good morning and good afternoon, everyone. So as many of you may already know, families that are taking care of children with special needs are already spending a lot out of pocket. A couple of years ago, there was an article in the Ottawa Citizen saying that families could spend up to $26,000 out of pocket just taking care of a child with special needs when it comes to equipment, therapies, respite, just the overall care of the child. And now with the impact of COVID-19, it's an additional burden for families, because at home, if you do have nursing care or if you have PSWs coming in, you're going to have to provide the PPE. And unfortunately, there isn't additional support to help families with that. And just recently on Twitter, a mom that I know said she's spending $730 a month just to purchase PPE because she has 24-hour care at home. So she has to provide all of these additional supplies for the nurses and the PSWs when they come in. So for families, this is becoming a huge concern of we already have to take care of our children, and now to keep them safe and to keep everybody within our home safe, we also have to provide this PPE that is not covered. In Ontario, this year, because of COVID-19, some of our funding, so SSAH, ACSD, and Enhanced Respite, the government expanded how we could use the funding. So they allowed us, they allowed families to be able to purchase PPE, which is great to have this fund, to be able to do this. However, this funding is usually funding that families use for respite or to get additional nursing care. So even though we're able to use this, use that money to purchase additional supplies that we may need, it's also cutting back on families who may need to get respite, because now the respite money is going towards providing supplies. And in Ontario, the government allowed families to get some of this funding to get 25% in advance, which again was helpful for families because at least they would have the money now to make the purchases if needed. In regards to how the supports can be better for families, I think it would be really great if the government would consider, once again, allowing the families to have more access to the funding that they've given them. So they did give us 25% earlier, but right now, because of all of the delays of COVID-19 and offices being closed, if you send in an invoice to try and get reimbursed, you could be waiting up to 3 months to get your money back. So if maybe something could be done so that families could get their money faster, or if families could have access to the money now, and I think that would be a great help to families, number one. Number two, the cost of PPE, as many people know, is very expensive. A box of masks, you're paying close to $70 for a box of masks. And if something can be done so that families that do have nursing care at home, PSWs coming in, they can buy these supplies at cost, I think would be a great benefit to families, because right now families are paying the amount that stores are selling them at, and it's just too much for families. So working with the LINs or working with some of the hospitals or other services that provide care, if they can look at providing these things to families at cost, I think would really help significantly with families. So that's my thoughts on that, and I'm open to hear what others have to say.
Thank you. Thank you very much, Lillian. Would anyone else like to jump in on that one? All right, great. My next question I'm going to ask to Thuy-Mai. So over the course of the pandemic, virtual care options have seen an increase in uptake. In what ways has this been beneficial to patients and their families? And what are the limitations of this virtual care?
Thanks, Carrie, for the question. Well, actually, now that we're really using telemedicine, and I will be defining telehealth here because there's actually a lot of things that are included in telehealth, but we're really speaking here about telemedicine, which is providing healthcare through telephone or visual conference as opposed to inpatient visits, in-person visits, I would say. And now I'm just trying to think why 1 year ago I was not using virtual health at all. And I think a lot of people are now thinking, wow, maybe this should stay even after COVID. Probably that some of the reasons were that actually hospitals and clinics were not ready to use telemedicine on the large scale. Just thinking at my hospital, which is a university health center, we didn't have a licensed program to be able to provide telemedicine with that would respond to safety and privacy issues. And the programs that were existing were actually very difficult to use. They were not user-friendly at all. Parents had trouble logging in. Even me as a healthcare provider, I couldn't figure out how to use it. So that's why we wouldn't be using it. So I think that the pandemic has really accelerated development of programs that are user-friendly and more easy to access. I think that the second reason also was that people are reluctant to change. Clinicians are very reluctant to change. So that's why we feel comfortable in our office. So this is what we're used to do. So why change the model? And actually, if we think about family-centered care, it makes more sense sometimes to actually move to the family house instead of having the family coming to the hospital. So I guess COVID made us, oblige us to change, which in this sense, that was a good thing. The third point was probably that we had some skepticism as healthcare providers about the quality of the care we would be providing, the human relationship, and I guess this is actually still up in the air. I mean, right now we're doing it because to respond to sanitary measures, but we don't have much metrics about, are we still providing good healthcare? And this probably needs to be studied in the future to make sure that the quality of care is as good when provided by telemedicine versus in person. And so like the advantages, we know what they are. Families actually are very satisfied in terms of reducing the travel burden. So if we think about families who might be traveling for an hour or even more to come to the hospital for a specialty visit, this is a big change in their life. And that possibly reduces costs for the family, but probably also the healthcare system. And also if we're thinking about families who have children with medical complexity, who are technology dependent, just thinking about bringing the gavage material, the oxygen tubing for a 30-minute visit, that's actually a lot of organization. So that's it's much easier for families if we can do it from their home to virtual visits. And also if we just think about the family experience, I do a lot of follow up with patients who may have with small children, and for them, like a 1 hour visit where the adults are speaking, that can be really long. So sometimes, especially if they have some behavioral challenges, it's staying in a room for 1 hour, it's too much asking for a child. So at least when we're doing it virtually, when I'm talking to the parents, it's easy for the child to just be playing in their environment and then come in front of the camera when it's required. So I think that for the family experience, it's much better in several ways. And even for me as a healthcare provider, to be observing what a child is able to do in his or her environment is very, very revealing. And sometimes we don't see what they're able to do in the office just because it's not their home, they're not familiar, and they feel very shy. And so it's really interesting to see how they can be doing at home and what are their strengths. One of the things also I've realized is I could be including other people to the visit. So for example, for one of the child, actually the educators at the daycare had a lot of observation and wanted to bring some information. And the parents agreed that they would be joining the visit. So I think it's very interesting with what telemedicine can offer us is to be including other significant people who are providing care in the and it can be people from school, people from the daycare, grandparents that can be included in the visit if the parents and the child agree. Now, moving forward, what are the barriers or the things that we need to think about? So in terms of on the clinical standpoint, so I think that telemedicine is very useful for certain type of visit, but maybe not all. And I would certainly not personally do it with a family that I don't know. I think we really need first, before going into telemedicine, we have to be able to build trust and a relationship. So I'm not sure that for a new family that we're going to take care of for a really long time, that doing it virtually is probably the best option. Because as I said, like there's certain things that you can't tell through the camera but it's much easier to assess in person. It's the human contact, it's the nonverbal cues. I think that's very, very important. I don't think it would be a good way to start doing all the visits by telemedicine. And the thing is also telemedicine, you can't do any physical examination. So I think we have to put some rules, or not rules, but some, I would say in French, encadrement, regulation, but that's not the right term, but some rules to make sure that, you know, we're doing still good medicine. So diagnosis that require a physical exam would certainly not be a good option. And the last thing I think we have to think about is making sure that access is equal for all. I think nowadays people are more familiar with technology, but we have to make sure that this technology is accessible to all, is easy to use also to all. And also in terms of geographic localization, some people don't have good internet access. So how to make sure that if we are to be moving to something that includes more technology, more internet, that everybody has equal access. And finally, the last point I would make is we don't know what the outcomes are. So we have to make sure that in terms of health outcomes, it's improving, not getting worse, and that the quality of care is the same. And just one last point that I would make is that during the pandemic, there was a significant decrease in access to healthcare in general, and telemedicine did not respond to all of that. So, I mean, we're in this pandemic probably for another year, I hope less. And we have to make sure that access to healthcare is still happening. And I really feel that there has been a reduction at that level.
Thank you. Annette had made a note in the chat box for tele-rehab. There have been some challenges in accessing secure platforms, also a need for some training and guidance on optimal uses to ensure that we integrate tele-rehab as part of future cost-effective healthcare. I know here in Manitoba that is a huge, huge issue because we have many rural and northern communities that our hospitals and our rehabilitation services do serve, so doing some of those over platforms. But there certainly are issues about practicing before you have a medical appointment to make sure that the family can use it, and that the services, the internet services are always going to be an issue in some of these communities. So thank you, Annette, for that comment. So would any other panelists like to jump in on that discussion? Yeah, Jeff, go ahead.
Yeah, thanks. Just a couple of observations from the Ontario experience. In terms of secure platforms, I think this is one area where I think government can play a role in helping with that. So we went through this in the Ontario school context in trying to figure out how we would mobilize mental health supports for students during the period that schools were closed. And so worked with our health agency here in Ontario to identify a virtual care platform that they had available that met all of the really stringent privacy requirements that are in place when personal health information is being exchanged, and make that available provincially to school-based mental health providers. So I think just supporting care providers, whether they're primary care providers or other health professionals, in understanding like what is the universe of platforms that are meet the sort of extra level of privacy that's required around personal health information, and potentially finding ways to make those more broadly available is one thing. The other thing I'll say is I've also seen here in Ontario both the health regulatory colleges and the professional associations really step up in providing guidance to their members about how to use these platforms. So whether it's, what their obligations are around professional standards and practice, if they happen to be delivering from their home, to make sure there's not crazy stuff going on in the background or whatever, just how to execute on their professional obligations, first of all, and then secondly, what are best practices around supporting patients or clients in providing virtual care. I think both the regulatory colleges and the professional associations have really done some thinking about this and provided some good guidance to their membership on, how to do it in a professional and ethical way, and what the best practices are in patient care. And I think we continue to learn more as we go through this experience. But I think those are organizations that can continue to play a role in promoting that with their members.
Great, thank you, Jeff. Al, I want to throw a question over to you. We've talked about some good things about what's happened and some bad things, but what's the next step? What do we do now?
Yeah, well, I hope that's an open-ended question that everybody will participate in, Carrie, but thanks for throwing it my way. It's obvious I'm an older parent. My daughter is in her 40s now, and I believe the panelists that have spoken so far are all parents as well as professionals. I think I've got that right. And certainly what I hear, what I read in the survey, and what I pick up across the country, but particularly in British Columbia where I am, is that parents are still struggling, still on their back foot, still having to be reasonable, moderated in how they speak about these issues, etc., in order to secure bare minimums during a pandemic. And they're not getting it. They're not getting the bare minimum. I think that's the way I would conclude the presentations and the data. So it breaks my heart to have a younger generation or younger generations of parents having to do the same kinds of things that we older parents did, and that we thought we were chiseling a few steps toward an easier path. I just want to say that. And I'd like to introduce the larger discussion, Carrie, by saying that what is the role of professionals as allies for families who are coming together to get the change they want? So I'd like to introduce that as a topic. I think there's an essential role there. So I'm talking about something beyond the technical expertise, the professional expertise that you have. What is your role as an ally, an advocate, in supporting the mobilization of families to achieve what they want? Secondly, I'd like to introduce, and maybe this organization, or maybe coming out of this, would be a Break the Rules award. Major foundations in the United States are awarding prizes and money for people who are being bold and going against the grain. The reality is that my nephew in Southern Ontario was laid off work, and within a week or two, he started receiving CERB benefits on a regular basis. There was trust built into their system. There was a breaking of all the previous rules related to how benefits were awarded and whatever. So I'd like to introduce that topic as well, as what can we do to leap over the constraints that currently exist. One that's been particularly vexing and perplexing to me is the lack of acknowledgement of families as an essential part of the caregiving team. It still boggles my mind that there is no respect for families from that point of view. So that's the second thing. And the third thing I'd like to suggest is that there is a movement developing within the disability community to secure more financial resources to families. It was started before the government, in their throne speech in September, promised to introduce a Canadian disability benefit. And so it's now supercharged. And what the disability movement has decided to do, led by individuals and families and their allies, is to essentially, forgive my language here, but take charge of the process, to not rely on the government to make sure that that happens, that it'll be a fair and equitable one, to not rely on government to do all the work in designing. And so we have launched an independently financed design and drafting process backed by public relations, backed by unifying the disability movement. So those are, Carrie, I've introduced 3 topics. I hope it's useful for this discussion, and I'm happy to come back and talk about any of those or to receive any feedback that people have. But essentially I'm saying is that in my observation, the changes we want can happen partially on the inside, but my observation over the decades is that they're going to happen when there is a partnership with families on the outside. And that kind of alliance is fundamental to not only getting the benefits we need during COVID, but rewriting the social contract for people with disabilities and their families afterwards. Thank you.
Thank you very much, Al. Would anyone like to speak to any of the questions? So what role professionals play as advocates and allies? Does anyone have, I know it's a tough question, but it's a really good one.
Yeah, Carrie, this is Dan. Yeah, I really appreciate Al for sort of throwing the gauntlet down in a way, in a very meaningful way, and 3 points of view that we could chime in on. I just, since we're sort of blessed with having a policy maker, Jeff, on the panel, I'd like to ask you, from your perspective on Ontario government, you know, if you saw those, heard those challenges that Al put forth, how would a policymaker in your kind of position, Jeff, respond most friendly to any things that, let's say, Child Bride could do in this regard?
Yeah, that's a great question. So thanks for that. Like for me, I think the most important thing that has been, you know, that I think has been the most important for us in developing, you know, what is school going to look like this year? And I think more broadly, when the government thinks about the impacts of the pandemic on persons with disabilities, is to find ways to engage with the community around, you know, what the challenges they're facing are and what they view as some of the emerging best practices to inform our own policy development. So I think, you know, we've tried to do that here in the province by engaging broadly on our planning. We have a minister's sort of advisory table on special education that includes a broad sort of swath of people, from educators who work with students with special education needs to people with special education needs themselves, you know, health practitioners, et cetera. We've really leveraged that table to try to understand what they felt was going on. There's other sector tables from various disability communities that we've engaged with. We've also worked closely with the staff in school boards. So at the Ministry of Education, we sort of set the overall legislative and policy framework for the programming, but it's all delivered by local school boards, and those boards have special education teachers and have superintendents that are responsible for that as a file. So we've engaged both with them and with the unions, as well as as educators on the ground. What are they seeing as the challenges and the emerging best practices to deal with them? So I think it's incumbent on us as policymakers to design our policy development processes to ensure that they're being informed first and foremost with, by the people that are impacted by those policies. So people with disabilities, students with disabilities, students with special education needs, and the kind of frontline educators and the administrative staff that are supporting them. And the frontline healthcare providers and the organizations that represent them, to get sort of a broad, multifaceted view of what's going on and what people see as the challenges and what are the best practices, and build those into the policy development. So that's, I think, one answer. I think there's lots of other things to think about, but I think it starts with the concept of bringing as many people into the tent as you can, and in particular the people that are going to be impacted by the policies that are developed.
Yeah, thanks a lot, Jeff, for that input. Yeah, bringing as many people under the tent resonates with sort of what I think about, and I think that's Childbride is trying to do in a real way, in terms of sort of creating a movement. And this kind of thing we're talking about could be just that. Cool.
Thank you.
Al? Yeah.
I don't know if this is helpful, but in British Columbia, as in other provinces, there was this major concern around families being part of the care team if their son or daughter or loved one had to go into a hospital. We know that this is a really urgent issue among families, particularly moms and dads who have children with complex needs, who are likely as capable of providing support for their son or daughter as medical staff are in most areas. And in British Columbia, we were actually able to finally get a policy legitimizing, validating families as part of the care team, but not without an awful lot of work. And our biggest ally was the BC Public Health Association. So it's a recommendation here, is that there's a more holistic view, in my opinion, of health and the role of families and the role of community in health than there sometimes is inside the medical profession. And forgive me, I'm saying this with respect. I don't know all of you and everyone who's on the call. It's just an observation over the years. Anyway, they came to bat for us and developed a position paper, had several meetings with Dr. Bonnie Henry. And in every one of their contacts with either Dr. Bonnie Henry or the Minister of Health or the Premier, they made sure that parents were with them. And they made sure that that family story was told. So I just use that as an illustration of a kind of dynamic that works really, really well. Most of us as families don't know the inner, outer of the public service, of the bureaucracy, or even professional, if you will, terminology sometimes. And so this combination is really important. Dr. Gary Block in Toronto now, formerly of British Columbia, has surfaced as a major ally in dealing with the financial issues that families are facing and people with disabilities are facing. So he has, instead of waiting for people to come to him, he has joined the community-based initiatives that are already underway, public policy initiatives, lobby issues, advocacy issues, families, and people with disabilities. So those are two examples of what I consider to be a really powerful combination of professional expertise and natural caring expertise. So I hope that's useful in terms of what I was trying to get at there with that role of allies.
Thank you. I had a note that Don had a comment that he'd like to say. He had his hand up. Are you able to unmute yourself there, Don?
Yes, I am.
Perfect.
So it's Don Mavitt. I'm the program head for the Neurosciences and Mental Health program at the Hospital for Sick Children, and one of the team leads for one of the Child Bright intervention programs looking at metformin for children with cerebral palsy. I guess a bit of a comment and question, and I'm interested in actually the perspectives of everybody on the panel, particularly in regards to bringing the big tent in, and also the critical need, I think, to establish guidelines and policy best practice right now. So just kind of the comment from my perspective as a psychologist who's actually married to a special education teacher who is delivering virtual care, virtual education from our dining room because she is exempt. There's a crisis right now for students with disabilities in virtual care, I would say. I'm hearing it from parents. I'm hearing it from my spouse who interacts with parents every day. And I think what we don't have, and we've already heard that I think students with disabilities are predominantly seeking virtual teaching options because of concerns. And certainly that is, I think, borne out in the experience of the anecdotal experience of my wife. We don't have actual really good guidelines and best practices available for teachers working with students with disabilities in a virtual setting. And we actually, in the same way we came up, and I'm from Ontario, the government came up with best practice for, protections from the COVID in class. I think we critically need best practices to help teachers and families understand the impact of virtual teaching on child development and mental health. Examples are things like families, caregivers feeling they need to sit and hold children in front of the screen because they've been told, their child needs to attend school. Understanding that particularly for young children who are in virtual school with a disability, interacting with the screen and maintaining attention and focus in that setting is going to be a significant challenge. And I'm just wondering if any of the panelists can comment on how we can, create such best practices now and get them out to teachers, families, community members now, because this is the crisis for children as far as I'm concerned. Thank you.
Thank you. Does anyone want to take that question? I know it's a hard one. It's a big one.
I don't know if I can answer the question, but I'm going to just give my opinions based as a mom who is doing virtual learning with my child, and also what I've heard from some other families is I just wonder if there can be better communication with the school boards. I know Jeff had mentioned earlier that they are in talks with the boards, but for example, a child who has, let's just say, vision issues, is nonverbal, sitting in front of the screen for 45 minutes makes no sense at all. So maybe giving the families an option of like, instead of it being 45 minutes, it's going to be 15 minutes. And let's just focus on what that child needs in that time. I wonder if that would be more beneficial to the family. I know another family of mine that I support, they have 2 children with special needs. And the school had given this particular family 2 different EAs. So the family has to go on at one time to do an activity with the one EA, and then they have to go on another time to do it with the other EA. So we wondered, wouldn't it have made sense for the family to have been given one EA where the mother can sign on at one time and try and do what she can to help the child, instead of giving 2 different times? So it became really confusing. And I find that some families are getting discouraged because they're finding that it's too hard to try, and if the child has behavioral problems, to try and get the child to sit for 45 minutes. And so that's what some of the schools are saying that the children have to do. So that is just my input of maybe better communication with the school board, and to give them some different ways to think out of the box of how we can still get that, how we can still meet the goals of the IEP, but maybe without the child having to be on for 45 minutes or, yeah.
Yeah, just a couple of thoughts on this. So I'll be the first to acknowledge that in this environment that we have this school year is no one's ideal school environment, and it's challenging on many fronts. Again, that for students with disabilities, it's disproportionately so. I think we definitely know there's more work to do on how we support students with special education needs remotely. This is, I think, relatively new territory for us, and we're all kind of learning as we go. And this is an active area of work for us, and we are trying to find ways to reach out to kind of frontline special education teachers and parents, and understand what their experiences are and how things could be going better. Just a couple of thoughts. I think first, remote learning doesn't have to be exclusively online virtual learning. There are other ways that students can, learn and do their schoolwork that isn't sitting in front of Google Classrooms or Brightspace or whatever it is for hours a day. There are other modalities of learning that can be done remotely, and so we're looking at sort of what are those and who do they work best for, and how can we make sure that boards are providing those. The other thing is, we've been really clear with boards that, probably for a lot of students, particularly those learning remotely, the content of their IEP, which is in Ontario, the Individual Education Plan, which is our sort of instrument for outlining, for those who aren't from Ontario, our instrument for outlining, what are the specific adaptations and modifications that are going to be provided to the student to enable them to meet their learning goals. Those need to change this year, right? If students are in different physical environments, then in some instances the modifications and adaptations and supports are going to need to be different, and IEPs do need to be updated to reflect that. And if for boards that have created standalone virtual schools that are not, the school that the child is typically attached to, their teacher in the virtual school has to have that IEP available. So there's been issues as well where, the IEP has not been provided in a immediate fashion to the virtual teacher, so they just don't even know what accommodations the child has in place. So it's those sort of kinks that we're starting to work out. But I agree, there's a lot more work to do in both figuring out what the best practices are and then spreading them throughout the boards. And I think as government, we definitely need help from educators and from parents and from students in understanding what's working and what's not.
Sorry, it's Don here again. I'm just looking at the Zoom chat and just the comments about lack of resources, and I think that's a key issue in terms of virtual learning. And I think I go back to, if if we could come up with some best practice guidelines to get out to school boards as quickly, and this is happening provincially, but I think it could happen nationally. In terms of numbers right now, I think in many virtual schools, the numbers of, say, CERTs, special education resource teachers that are available there to actually make the IEPs available for classroom teachers to have, they have a much higher caseload than what they would have had in real school. In terms of, so for example, Jeff, your comment about online learning not being in front of the screen, I think that's a great essential idea, but it's not being realized in the school boards because there tends to be this focus that, and actually mandated by school boards, depending upon the board, a child needs to be online in front of the screen learning for X number of hours. And whether that's being misinterpreted, I don't know, but I think the opportunity for teachers to hear from parents, like I think what Lillian just said, and then the ministry to help provide. We're talking about Ontario, but I think this is relevant to all ministries of education across the country. Best practice to say, this is entirely new. And this is entirely new for working with students with disabilities. But here's what we've learned so far. To me, my great anxiety is the impact on our students with disabilities are being disproportionately impacted, and they're not going to get this time back. And these are critical months. These are critical years for these children. And so it's a crisis that we need to address now. And so if there's a means to, either at a provincial or a national level to, do a quick convene of some kind of consensus group to get the message out. At Sick Kids, for example, we came up with a policy statement about going back to school that was cited by our government. I think it turned out to be a good policy statement. I think it was applied appropriately. I think maybe we need to come up with a policy statement about virtual learning for, maybe ChildBright wants to come up with a policy statement for virtual learning for students with disabilities, because it has to happen like last week. Anyway, I'll get off my soapbox.
Yeah, great
Want
comment.
to jump in? Al, yeah, go ahead, Al.
Yeah.
Sorry, did you say Dan or
Go ahead, Al.
Okay, you'll have to forgive me again, but I'm talking here as an advocate, long in the tooth. And I jokingly said break the rules. MIT for several years had a disobedience award. But let's call it a think outside the box award. The reality is we are seeing in many areas of public policy today that everything that couldn't be done before is now being done, and immediately. And so all kinds of rules are being broken in that way, metaphorically at least, and people are responding. And so here we have a situation where, if I understand Donald correctly, we could quickly consolidate what the best practices were for a large number of students with disabilities who are being taught virtually, or should be taught virtually, in a very creative, innovative way. And part of the resolution of that is financing. And so there's two obstructions to it, it seems to me. One is the intransigence of, or the momentum of outmoded approaches. Notwithstanding the need to move, the reality is that many systems are very slow to respond, very reluctant to respond, and they won't respond unless there's a concerted lobby effort from the community to go directly to the politicians with some of these new ideas. So I just put that on the table. Also would say that likely, it's the 80-20 rule, but that likely there are going to have to be even more customized learning opportunities for some students with disabilities. Let's say, 20% of them who don't fit into some of the more general best practices that might be out there. And I commend to you, if you don't know her already, the work of Professor Jutta Treviranus from the Ontario College of Art and Design. She is a world expert at inclusive design. And if ChildBright, in concert with other professionals and families, could design a process with her to ensure that everyone is included in this policy, I would commend that as well as another piece of going to government. But I can't see these issues as simply a matter of getting the best practices and using reason with the system. The reality is we have to use our emotion, and we have to use our connections and our relationships with the political process. We have to become engaged citizens to make this happen. Reason is not enough. It's important, but it's not enough. So, and I mean no disrespect for our public servants. There are many in there who are waiting for this kind of initiative because they know what you're saying is true.
Thank you, Al. Dan, you had something you wanted to contribute?
Yeah, thanks a lot, Carrie. Yeah, this has been an incredibly interesting and stimulating discussion. It seems like what Dawn has sort of brought up really aligns with what Al talked about in terms of, especially in terms of respecting the family. I think that's hugely important. And I think this could be a real item to move forward on for ChildBright. And maybe if any folks out there who would like to just put into the chat box if you'd be interested in participating in this effort going forward, we can form an ad hoc sort of group and maybe engage our panel who've been sort of very stimulating and thinking about this also. It would not only be the best practices guidelines as Dawn suggested, but really as Al's pushing on, which I totally agree with, is something much bigger than that, that would form a lasting sort of effort going forward. So yeah, and any further comments on that would be great. I have seen the chat box. Brenda has put in some really cool ideas that's happening in British Columbia. So let me turn it back over to you, Carrie, to sort of moderate us through this exciting sort of effort.
Yeah, I think that's a really great takeaway. We have one very concrete thing that can be done and can be done, I think, quickly, that will support education for our kids and for the families that are doing it. And it doesn't have to be a document that's once and done. It can be a continual document that is changing. And it may change some of the homeschool that happens all over the place as well. So I think it's a great way. But does anyone else have any other comments they would like to make around this? But I think it's a great takeaway. Lillian.
I just wanted to add, like what Jeff had said earlier in regards to, virtual learning doesn't mean that you have to sit in front of the screen. Again, I think that's like a really great idea, and it's great to bring that information back to the boards. But I think when you're bringing the information back to the boards, you should also give them concrete examples of what other options they have, because I think right now everybody thinks, okay, virtual learning is we have to be in front of Zoom. But if we don't have to be in front of Zoom, or we don't have to be in front of the screen, what else can that look like? So I think concrete ideas would be really helpful to the school boards, and then they can then see how they can implement that. Like just saying it doesn't have to mean you have to be in front of the screen doesn't really mean anything. They don't have any other ideas.
Great, thank you. Actually, I'm going to go one step further in that. I'd like as many people as possible to put it in the chat box. And panelists, I'd love each one of you to speak on this. It can be about directly what we're speaking about right now, which is the education, but if not, something about your practice or what's going on with you is what has gone well. So during this pandemic, what change do you want to keep after this is over? So if you have any suggestions of one education thing that worked well, or anything to do with the health or anything like that. Twee, Mai, can I just throw it to you first in terms of what is the one thing or what is a couple of things that you really think is important to keep? And everybody else who's here, please throw your ideas in the chat.
Well, I think I mentioned it already about the providing virtual healthcare. I think it has a lot of the advantages. I'm actually going to go back to, if I'm allowed, to one of the things I'll mention regarding having allied. And I totally agree with you, because I think it has a lot in terms of the medical profession, at least if, because that's the one I'm familiar with. It really has to do with how medical students, residents, and doctors have been raised in that medical world. And I think traditionally it has been very, a very paternalistic approach, where the doctor has the truth and like other people have to listen. And that's the old model that I hope will go away with time, because and what I see on the field, at least at my hospital, is parents have been more and more involved in ethical rules on how healthcare should be provided. So we have a new ethics policy about how to really incorporate families into the care. But this actually has to start right from med school, and not once the doctor has 20 years of practice. And we really have to think about how, and maybe even like who should be entering med school? Who should be those, the next future, the next generation of healthcare providers? We've been focusing on grades, but how about the human factors, and how do you assess human factors? I think that's a big thing that medical schools have to think about. And I think you have to start with this. We have to continue, of course, with the people who are on the field, but probably that if we want to make really big change as we move forward, education at the beginning has to, we have to think about that also.
Thank you. Lillian, do you want to go next?
Oh, well, for us here in Ottawa, like one thing that has been working well for us at CHEO, and this is not in regards to education though, but one of the things that we started doing is, as we are dealing with families that have children that are medically complex, one of the big things is isolation for these families. And so we had started doing a virtual parent group, and we'd run that every week. And this is something that we hope to keep on after the pandemic is over, because the response has been great. And we tried to actually have the parent group pre-pandemic, and it did not work as well, just again, because it was hard for families to travel and to get to the location. But with it being online, virtually, we're able to get families that cover all the CHEO areas. So it's been really great. So that's something that we hope to keep on.
Yeah, and I totally agree, Lillian. I think before we had patient advisory boards, but patient had to come to the hospital to participate in these meetings. But now that everything is happening on Zoom, I think it actually gives an opportunity to get a larger access to families who are interested in being involved in those different advisory boards that has to do with either, I mean, in terms of healthcare, health research, health education. I think this is certainly something, that with the virtual world will be able to keep and facilitate. So families are more involved in how healthcare is being provided, and probably education also.
Mm-hmm.
There is a movement around the world for increased democratic representation and decision-making. So it's not just something like proportional representation, it's about new ways of engaging with government, new ways that citizens can engage with government, and beyond the typical process where we wait for government to establish an advisory process, and we hope that some of our people we respect get on that committee, and then it's a very laborious process. These new ways really include citizen juries, citizen assemblies, and the like. And one of the world's experts and working incredibly with governments across Canada, but an expert is Peter Macleod. His company is MASS, M-A-S-S, LBP. And I just commend you to him. We just recently had a webinar with him to the disability community. We had about 500 people on. And so we're wanting to learn new methods of democratic engagement that get out of this silly process that hasn't worked very well pre-COVID. And so Maya and Lillian, what you're talking about is exactly true. And so let's learn a little bit more about what these methods are and implement them. We've retained Peter to essentially direct the design and drafting process to establish the Canadian Disability Benefit. So instead of waiting for government to set up their advisory process, we've taken the lead and we'll bring together a group of experts advised by families and people with disabilities and offer that to government. So in the disability world, nothing about us without us does not mean waiting until government says, okay, come on to our table. It means building our own table, setting the agenda or menu, and then inviting our partners in government. So it's a much different way. It's a democratic revival as well. So I just offer that as a framework for everything that we're doing. And so as professionals, how can we, and allies, how can we get behind that? As public servants, how can we reinforce that inside but we have to rethink democracy in order to rethink disability and in order to rethink this balance between natural supports and professional supports.
Wow. Just a couple of things in the chat. Rachel has posted some information in regards to advisory, so please take a look at that. As well, Dan, you had a question about diagnosis and being outside the box. Did you want to ask the question?
Yeah, sure. Well, also to make an observation, first, as it's the most recent, is what Al just talked about, sort of the democratization of this process. And I think I would highly recommend to those who haven't heard it yet, Jennifer Johansson and colleagues, Matters of Engagement. It's a podcast that she puts on that it really speaks to this issue. And Al, if you don't mind, I recommend you to be on that podcast with Jennifer. I think the discussion that we're having right now is totally, I think they would sort of be on a launch pad with you. And they're wonderful patient engagement and lived experience individuals. The other thing also as a follow-up to Al's awards, and we're not sure what we're going to get with these awards of the out of the box or the disobedience awards. I'm not sure if that's something that maybe Child Rights should think about, but in terms of that, so we're doing sort of working with parents and patients. What about sort of out of the box in terms of diagnostics, that is using sensors or phones or distant kinds of assessment tools to be able to bring forth a better diagnostic picture, and then to go forward with maybe more honed interventions. So I'd love to hear your thoughts on that, Maya.
Well, I don't want to be, like not an advocate of progress and innovation, but I'm always a bit skeptical until it has been, well studied. the danger is always that, you know, it's a big market and people will, I mean, there's always money behind that. And I always wonder, you know, all the companies that develop those new tools, if, you know, they're more interested in how effective they are versus how sellable they are. So for any new tools for assessment, I think we have to be very open to it, but we have to make sure that it's actually working and that, you know, the assessment is being done through rigorous research. And I guess I'm speaking as a scientist here, and I mean, you're part of this, you're also a researcher, Dan, so you probably know what I mean. And this is ultimately to make sure that we're, you know, that patients have access to high quality of care, and that we're also not replacing also the human factor by just health technology. I mean, I think health technology is good, but it's not going to solve all the problems. And we just have to make sure that we have this right combination of, you know, keeping this human factor and making advantage of the health technology to make everybody's life easier. But it has to be studied to make sure that, you know, we're still moving forward and not, you know, regressing in any ways. So that's my opinion.
Yeah,
I hope
thanks.
I'm answering your question. Gary, you're on mute.
So we only have about 10 minutes left. Thank you very much. So I just wanted to bring up something that is, I think, really important to families across Canada. And you can see it even in some of the chat box things. People are bringing up services that they have. So my question to the panelists, and please anyone can answer this, is access to services, the way they are delivered, and in many cases, even the types of services available in each province and territory are vastly different. What can we do to create an equitable and hopefully positive, so hopefully we don't go backwards, but hopefully a positive experience for children with disabilities, no matter where they live in this country? The hard one. Apparently no one can answer that one. All right. Yeah, I've been struggling with that one quite a bit. If anyone starts to have an answer, please put up your hand, because I do feel like, you know, the things that Brenda's been talking about in the chat box, that's certainly not something that we have here in Manitoba, nor have I heard of it in many other places. So she was, yeah, so there's certainly huge inequities across provinces. And I do wonder how we can get together and do that. Al, I wonder if it's something about the movements you've been talking about, if sort of any of that might be relevant.
But I also wonder though, in regards to that though, like, we want it to be equitable for sure, but from province to province, what may work well in one province may not work well somewhere else. And like, I know here in Ontario, like one of the things they've started looking at recently is family managed care for families that are receiving services from the LHIN. So this is in regards to the medical care. In the past, as families, we had no say in regards to the agencies that provided services. And sometimes your house would become a revolving door. You have so many care providers coming in and out, in and out. And in the past, I believe 3 years or so, they've started doing it where families can be in charge of who they hire. So you're hiring the person, you're doing the training, and at least there's some stability in your house. And I believe out west in Alberta and BC, they actually already have something similar where the families are already in charge of who does the hiring. And I feel like this is really beneficial for families. And I don't know what you guys have in Manitoba, but it's nice for families to have a say and be part of the care that the child is receiving instead of it being dictated to us.
Thank you. So one other question that came up in the chat is, do we think that families are, Twee, I just saw you unmute yourself. Twee, did you have a comment? Go ahead.
Yeah, as Jan said, I don't think there's a one model fits all, but the other thing in the disability world, the patients that I see, I also find that there's there's iniquities in general for families with children with disabilities. It's so much harder for a lot of things, but when we think about families from minorities or immigrant family with children with disabilities. I think this is even harder. And one of the questions I have is, how do we reach to these families? And I'm not sure we'll have the answer today, but in all the endeavors we're doing, I really want to make sure that these families who are sometimes in very difficult situation, that we don't forget them, because they don't go to family advisory board, they don't connect to Zoom, they're struggling, just trying to figure out how the system works. Maybe Lillian, you have, as a navigator, parent navigator, you have a better idea of how to make sure that new immigrants, families from minorities are really included in all these endeavors.
I know that with the Navigator program, so because of so it's myself and another mom that are parent navigators. And for me, on my family load, like I do have some families that English is not their first language, and we work with a translator. So our role is once a month, we're checking in with the families and we're making sure that they're aware of what services may be available to them. I'm not a social worker, but we do have a social worker on the team. So if I notice that something is missing within that family's, what they need, I let the social worker know so that they can help advocate for that family. But unfortunately, you know, we're only dealing with families that have children that are medically complex. There are other families that have children with disabilities that would benefit from the same sort of service. But it's something that is lacking, because we do have a majority of the population that are newcomers. They can't speak English, or they're just not aware of our system, and you're trying to get comfortable in a new culture as well. And so where is that information coming from? It's something that is definitely missing.
And that actually ties into the question I was going to ask. Jeff, I'll let you in a moment, but Annette had asked earlier in the chat box, do families know about all the supports? And I know in Manitoba, because they come from so many different organizations, and even the social workers who are, or the community workers who are working with the families from the government, don't know about all the services that are available. It's really tricky, I think, for families to be informed. Jeff, I'll throw it over to you.
Yeah, so just I'll kind of, I guess, maybe try to tie these two questions together. But like to Lillian's, I'm going to join Lillian in sticking up for Canadian federalism here and saying, first of all, you know, I do think there's a role for the federal government in providing funding and establishing standards attached to that funding. But I also do think, you know, to Lillian's really excellent point, different provinces are different, and so need the flexibility to be able to implement programs that work best for their populations. But it's also the case that, you know, it also creates an environment where provinces can innovate, try different things, and, you know, researchers can look at them and go, oh, that worked really well, other provinces should look at this. So I think there's a role for, you know, the flexibility that provinces have to innovate in different spaces, and then for researchers, advocates, you know, communities of interest to look at those things and say, wow, that's actually working really well, or maybe no, it's not working, and, you know, help us understand what's going really well in BC, what's going really well in Manitoba that could be adapted in the Ontario context. So I think, you know, that's part of, it's important to, I totally agree that there's inequities that we need to pay attention to, but we don't, in trying to squeeze them out, we also don't want to lose the kind of dynamism of federalism. And then I think, I do think it's a case that people don't know what programs are available to them, and that's where I think there can be a really great role for peer navigator or parent navigator kinds of programs like CHEO has, like some of the other children's hospitals have, because, you know, I think in government, we make best efforts to kind of make people aware of the programs, but there's often such a mishmash. And there's no substitute for kind of lived experience with that. So, you know, I think the those kinds of parent navigator, peer navigator programs are really, really important in providing support for families who are new to this world.
Thank you, I agree. Al, did you want to, I think we're asking, there's questions being asked in the chat box about, yes, we need to do this. So what's the next step? Where do we all get together and move this cause forward? Where do we sort of start on that?
Well, we can, and I know many of the people on the call are part of it, but we essentially are creating a table to not only secure the Canadian disability benefit we want, that's a financial wing, but to build the apparatus so that we can tackle all of these other issues so that we don't have to take years and years to get, you know, one initiative dealt with and then all of a sudden 15 other challenges pick up. So I'd invite you to, I think the easiest way is to contact, you know, I'm happy if you want to share, I don't know how to say that, I have nobody to help me here, but if you want to share my email or the Executive Director of Plan, Rebecca Pauls, I'll send that to you to connect into some of the stuff that we're doing. That's a place to start. We don't pretend to be the only thing, but essentially we're building a pretty big tent now. Everybody preserves their own autonomy as an organization, and we agree on our common objectives and go forward, and we get to know each other. So that's in play now, and it's just going to get bigger and bigger. I don't know if we're near a time. I just want to say one thing. What I've learned about movement building is that we have to watch our language. There are enough statistics and analysis about what's wrong. Those don't touch people's hearts. If we don't touch people's hearts, their heads will not follow. We can't get caught in this trap of thinking that all solutions derive from a rational base. They don't, not in politics at least, and not in my own life. And so I would invite people to think more about rallying the brokenhearted and the half-hearted and connecting them up with the open-hearted and the brave-hearted. That's part of our job as well, is to provide recognition of what we're all going through, as has been so amply demonstrated by the report you did before this session and on this session today. There are a lot of us who are brokenhearted at what we have to go through in order to secure the very basics. That's what we're doing as much as we're analysts and professionals and statisticians and diagnosticians, etc. So let's rally the love sick.
Well said.
Thank you, Al. On that note, I think we need to wrap up this discussion. Thank you all so much for joining us, for sharing your knowledge. Thank you, panelists, for sharing your expertise and knowledge and stories with us. I agree. Part of this is the storytelling. Part of this is getting people engaged and getting people together. And so we will send out information on the organization that Al is talking about, as well as a few things else that have come up in the chat to all the people who attended. Thank you very, very much. This was a great discussion, and we will let you know what steps we are taking as we move forward to create this discussion and to figure out what are those things that can come out of here, and who can we push to do the things that we want. So thank you, everybody. Have a great afternoon or morning, and we will keep talking.
Thanks a lot, Carrie.
Thank you.
And the panelists. Yeah.